So I'm Joe Sepulveda. I'm the Chief of Psychiatry over at Family HealthCenters of San Diego. I also oversee the Substance Use Disorders department from a medical standpoint with my colleague, Katie Wood. Katie?
And good morning, everybody. My name is Katie Wood. I am the Senior Director of Special Populations at Family HealthCenters of San Diego. I oversee the operations of our Substance Use Disorder Services team, our Syringe Services program, Harm Reduction Services, and a variety of other programs and service lines that we have that offer low barrier access to life-saving medications and treatment for substance use disorder.
Okay. So today, we're going to talk and really focus on stimulant use disorder, namely methamphetamines, and talk about the treatments involved with it, as well as contingency management. I know the title that was sent out was contingency management, but really contingency management is one of the tools that you have at your disposal of the many tools for dealing with methamphetamine use. And so I wanted to make sure we review those. I have no disclosures or financial conflicts of interest to disclose today. So San Diego, it's a beautiful place. I'm not from here originally. I moved here, oh God, I want to say 15 years ago, but it is a very, very beautiful place. Yet there are some issues when it comes to this region with methamphetamines. Historically, this is really where methamphetamines first made its way to the U.S. and started spreading out to the rest of the nation. There's a really interesting book by an investigative journalist that wrote about this, and the book is called Methland. If you guys are all interested in knowing the history behind it, the author was Nick Redding. It's a very interesting read, but this data is coming to us from the San Diego County Methamphetamine Strike Force report card for 2024. And one of the things you can see here is that when you look at unintentional methamphetamine deaths, you can see that the numbers are increasing. There is a little bit of a dip in 2023, but I think we can all agree that that number is still very high compared to 2019 numbers. Now, when we look at what a big problem our county is suffering from, which is not just methamphetamine use, but also fentanyl use, you can see that the numbers here are increasing as well when you factor both of those substances into deaths. And then you get your other statistics here where percent of total unintentional overdose deaths and, the rate per 100,000 people. And you can see that, those numbers are following like so. When we look at emergency department visits with methamphetamines, you'll see a similar trend that was coming about, which was in 2019 to 2021, the numbers were increasing. Now, interestingly, in 2022, the numbers came down, and I wish I had more recent evidence, but this is as far as the report card goes, as far as what the numbers are right now. But when you look at overdoses with opioids and amphetamines, you can see those goes up as well as far as ED department visits. Now, it's smaller than the actual deaths, but nonetheless, it's a trend to pay attention to. Now, this is an interesting graphic here where it really lists all of the the top substances identified for unintentional overdose deaths in San Diego County. And it breaks it down into from left to right, methamphetamines, fentanyl, heroin, alcohol, cocaine, alprazolam, which is also known as Xanax, and methadone. And, you could bear the numbers here and you can see that the numbers are just increasing. But the major offenders in the county, at least since, 2020 all the way up to 2023, and that trend is still the case now in 2025, which is methamphetamines and fentanyl are really the major offenders when it comes to this across the county. Here's yet another depiction of a Venn diagram that shows you the issues we're having with methamphetamines and fentanyl and the overlap between them. On the left-hand side, you can see in 2023, the number was 413 unintentional overdose deaths. That's 34% of what you see there in the Venn diagram. And if you look at the right-hand side, it's methamphetamine and fentanyl without the presence of other drugs, such as alcohol, alprazolam, and cocaine. You can see those numbers are obviously concerning. So what are the populations, the ages, who's affected by methamphetamines in the county? And this is a very interesting slide here, depiction of information. Now, if you look at this, Let's start on the right-hand side here. You'll see that we have a total number of overdose deaths of 756. Now, males are disproportionately affected. You can see the age ranges here. And you can see that the vast majority of people that are affected are going to be Caucasians, followed by Latinos, right? And then you get some smaller numbers here of African Americans and Asian Pacific Islanders. The interesting thing, though, when you look at it from our region is if you look at it from a rate of 100,000 residents, then you see the numbers really change. You'll see that African Americans are disproportionately affected when it comes to these deaths. And that's really interesting, right? Why is that the case? And how do you intervene in these populations that are of color? And it's a question that my organization has been really trying to wrap our heads around of how do we engage these individuals into care? We're a large FQHC. We're in every region where there's people of color, and we serve them and have been for decades. Yet the vast majority of what we're seeing are Caucasians engaging in care for contingency management or for methamphetamine use. Not many African Americans, even though we know they're disproportionately affected. And Katie can talk more about that later. And you can see the age ranges here that are affected for 100,000. Now, geographically on a map, this is also interesting. If you're looking at the left-hand depiction here or graphic, you're looking at methamphetamine overdose deaths by resident zip code. And you can see there's a large concentration in downtown, just east of downtown. You'll see it in the south, and you'll see this region up here that's affected as well. But there's a vast concentration right here in downtown. Now, when you look at ED encounters, obviously you would expect the same thing to follow, and it does, right? Map basically looks the same as it does over here. So those are our San Diego hotspots. This is pretty sobering. So this is people that were arrested, how their report of whether or not it was easy or very easy to get methamphetamines. And you can see here that it's way too easy to get methamphetamines out there throughout the county. And it's just getting easier as the years go by. And, you know, it'd be interesting to see what the 2024 and 2025 reports are. But from my taking the pulse on the ground in my program, it's just way too easy. It's basically in the water here in San Diego. So we went over depictions of overdose deaths, not just with methamphetamine, but methamphetamine and fentanyl mixed together. And this is a slide or a study back in 2019 that really brought this to the attention of a lot of clinicians. So one of the things that we started seeing back in 2019 when this was published, and as early as 2014, was that there was a rise in having contaminants of fentanyl in cocaine. And that made sense, right? Because cocaine is like a powder substance, it's easy to mix in. You would expect that to occur at some point. Methamphetamines it's harder, it's a crystalline form of a stimulant. And yet they were able to get it into methamphetamine as well. And you can see that here on the bottom line, which is yellow, and its uptick. So it's not the easiest thing to do, but yes, it can happen. So it's just something to be aware of. And that's another reason why we always recommend as clinicians that if a person is using methamphetamines, that they also use Narcan. Whether it's mixed in there and they don't know it's mixed in there, or they're actively using both substances at the same time, it's really important for them to have Narcan on board for that opioid that potentially could end their life. There's a lot of good material out there for evidence-based care for stimulant use disorder. This is just one of the many resources out there that's provided by Samsung. And I would encourage all of you to go to the Samsung website, download some of these training documents so that you get a very good handle an overall picture of what it is that it takes to not only treat methamphetamine, but to develop programs around treating stimulant and methamphetamine use in your programs. It's all evidence-based. There's a couple of things I highlight when it comes to treating stimulant use disorder. The gold standard has always been psychosocial treatments, and that is things like contingency management, motivational interviewing, which we'll go over in more depth, and others. But it's really a triangle that we think of when we're supporting people with methamphetamine use and we're getting them into treatment. The gold standard will always be what I just mentioned, but there's also counseling, there's additional support that we can offer them, and there's medications as well. Now, when it comes to medications, I'm not going to sugarcoat it. They're not as effective as what you see for methadone and buprenorphine for treating opioid use disorder. In many of those instances, when you treat those conditions with those medications, you'll be able to elicit a very good response from individuals ceasing to use opioids. I wish that were the case for medications. The number needed to treat, which is how many people you need to treat to get the desired outcome, is much higher when it comes to medications for stimulant use disorder as opposed to opioid use disorder. So just keep that in mind. It is an important thing to have in your tool belt and to prescribe to individuals that are suffering from stimulant use disorder. But you also have to keep in mind that medications alone may not really be as effective alone. You may have to incorporate the other aspects of care. Now, the goal really for stimulant use disorder is to make sure that the tools you have available to you and the treatments you have available to you are easily implemented in a variety of settings. And all of you are, I'm sure, are familiar with the levels of care when it comes to substance use or ASAM criteria, right? You have from outpatient all the way to medically intensive inpatient services and everything else that's in between there. And all these psychosocial treatments, medications, and everything else that I'm going to present to you today, there's something that you can do in each step of the way when it comes to this spectrum of treatment that patients are going to receive. So, the last thing you need to hear or you want people to think is that they're not able to do something for a patient if they're in a medically managed intensive inpatient service, or if they're in level 2.5 or whatever it may be. There's always something that can be done for someone that's suffering from stimulant use disorder in any level of service that they receive. So when it comes to the psychosocial treatments that I briefly mentioned before, there's 4 approaches to address stimulant use disorder that are evidence-based. And these are really the gold standards, with contingency management probably being the one that has the most robust data to support its efficacy for those that are struggling with stimulant use disorder, namely methamphetamines. But motivational interviewing is very important. It's often the thing that gets patients the motivation to engage in care. It can be implemented by anyone. It can be implemented by clinicians, non-clinicians, SUD counselors. It can be implemented by a treatment setting. Anyone can do motivational interviewing, but it does require some training and some expertise. Contingency management, again, is a gold standard. Historically, it's been used in the VA with a lot of success, where the vast majority of studies come from, indicating that it's very effective. It hasn't really made its way into what I call, quote unquote, the real world, which is settings outside the VA. And it largely has to do with making sure that the positive reinforcers that are given they benefit the individual. And there's a monetary aspect to that. And that's really been the hindrance, is that monetary aspect associated with the positive reinforcer, that a lot of people are not willing to cover from an insurance standpoint. And I'm sure Katie can talk more about that when she when she takes over the PowerPoint. But that's really been the barrier for getting it into the real world settings like ours. Then there's community reinforcement approach, which uses various techniques and various ways of getting people to move away from using substances, which I'll go into more detail later. and cognitive behavioral therapy, which I'm sure many of you are well aware of, which is changing someone's thought process of how they perceive their situation. Now, this is straight out of SAMHSA, one of those training materials that I pointed out, and it outlines the 4 psychosocial interventions that I just mentioned in the previous slide. And as you can see here, when you move from left to right, you'll see the practice of motivational interviewing, contingency management, community reinforcement approach, and cognitive behavioral therapy. And right below that, you'll see the review rating as far as the evidence base behind it. And they all have very, very strong evidence base supporting their use for treating methamphetamine use disorder. The focus of each one is obviously different. When you look at motivational interviewing, you're really trying to resolve a patient's ambivalence and feelings for their insecurity in being able to attain abstinence from a specific drug. And you're rolling with that ambivalence and you're trying to shift their ambivalence toward change. And that's really the efficacy of where that intervention comes from, is where you're really making the individual come up with their own motivations and their own drive for wanting effective change and thus engagement in treatment. That can be applied in the outpatient setting, the inpatient setting, as you can see here on the other columns. There's specific training available for that. I would encourage everyone to get training for motivational interviewing. This is one of the things that as you master motivational interviewing, you get better and better as you practice, and it becomes more and more effective. It can be, anyone can do it. It's been successful in male and females. Specific populations where it's shown robust data, and really this is just based on the large proportion of data that we've used to study its effectiveness. There's a large database where men who have sex with men have had success with this intervention, but again, it's not just restricted to that. It's just where a large proportion of the studies indicate great success. There's no duration to this stuff either. There's no recommendation. It could be implemented throughout the entire treatment course of an individual, throughout the entire life of an individual seeking treatment, and every primary care visit or psychiatry visit, whatever it may be. It can be as long as a few minutes. It can be as long as half an hour or longer. Contingency management, again, that's probably the gold standard when you're looking at outcomes. It uses positive reinforcers, which we'll go into more detail in a bit. You can see here that you can use it both in the outpatient and inpatient setting. This usually has a prescribed period of time in which you're implementing the services. Typically, it's about a 12-week program that you engage patients in, and then patients graduate, and then you continue treatment in the outpatient setting or with their addiction treatment program team. Community reinforcement approach. So community reinforcement approach really tries to identify behaviors that reinforce stimulant use or other drug use. And what you're trying to do is you're trying to find or substitute other substance-free lifestyle changes into their daily lives so that those are more rewarding than it would be to use substances. It's been used in a wide variety of settings, and there's been a large number of studies indicating that adolescents in particularly benefit from this type of approach. Again, there's no prescribed intensity or duration of time, but most programs are going to run about 24 weeks in doing these kinds of services. And then there's cognitive behavioral therapy, which I'm sure all of you are aware of. It's changing people's mindset and perceptions into their situation. And that usually has anywhere from about 5 to 10 months of treatment in order to see the changes that you want to elicit. So motivational interviewing, and I know we briefly talked about it, but what is it? It's really evoking change talk in individuals. And the key here is that you're not pushing an individual towards something. You're not telling an individual what to do, but you're trying to make them find their own motivation through their own words of why they want to engage in treatment. Part of why people do not engage in treatment. And it's really getting around that ambivalence and for them to find their own motivation to engage that really makes a difference and is a success in this. Now, it's not just in substance use disorders. Motivational interviewing has been shown to be very effective in the primary care setting for any number of diseases that primary care physicians have treated. And this is a very important distinction here because a lot of times I hear, well, patients that suffer from substance use, they're just not motivated to engage in treatment. It's a lost cause. They just, they're always relapsing and it's not working out. Well, same thing happens in primary care, which is why motivational interviewing has been used in primary care. Patients struggle the same way they do with addiction, whether it be diabetes, heart conditions, thyroid disorders, whatever you name, whatever condition you treat in medicine, the same thing happens for chronic diseases, for someone that really has to be on top of their treatment for the extended period of time that they're going to have the disease, which is chronically and for the rest of their lives. So, again, it's no different. Primary care struggles with the same thing, and this has been a very effective tool for people to make change. Now, one of the key things to highlight here, which I mentioned last time, is that there's no prescribed time or period for which you're going to do this. So a lot of times you'll hear, well, like I said earlier, you're going to do 12 weeks of contingency management. Well, that's not really the case with motivational interviewing. Every opportunity to engage the patient, check in with them, is an opportunity to invoke change. And whether it's a few minutes of a conversation that uses motivational interviewing, or like I said, a half-hour visit, it all plays an important role in the treatment of an individual and is an important reinforcer. So in our program, if they were to meet with the SUD counselor, if they were to meet with the psychiatrist or the primary care physician, if they were to meet with the therapist, we would want to use motivational interviewing as a tool each and every time we engage with the patient so that they reinforce their motivation for ongoing treatment and care to ensure success. Here are some resources that one can use. PCSS has some really good training resources for developing motivational interviewing techniques. Would encourage all of you to look at those, but also look at conferences where they offer motivational interviewing. It would really, believe me, it really changes one's approach, and it's amazing how much success one can get once you implement MI on a routine basis. All right, let's talk about contingency management. What are some basic assumptions about contingency management as far as why it works and why it's efficacious? Well, when you're talking about contingency management, you're talking about changing behavior by using a positive reinforcer toward effective change. And what I mean by that, if anyone here took Psychology 101 back in college, all of you are familiar with operant conditioning, or you've heard of it, right? Operant conditioning is a type of associative learning process through which the strength of a behavior is modified by reinforcement or a punishment, right? But here we're talking about a reinforcer. And the behavior is controlled by that external stimuli. So what does that mean in English? It means that if the target is methamphetamine use and a decrease in use, then you're going to have to find a way to monitor that, which is a urine tox screen. And if the urine tox screen is negative for what you're looking for, which is a decrease in methamphetamine use, then that objective data is going to elicit a reinforcer to the patient to say that they're doing well. Okay. What that looks like in the program is that someone will come into a program. They will typically check into a contingency management program at the beginning of the week and at the end of the week. They'll do a urine tox screen at the beginning and end of the week. Immediately when that urine tox screen comes back negative, you are going to give that positive reinforcer, which is in our case, a voucher that has some monetary reward, to the patient. And that positive reinforcer, each and every time they're negative for urine, is going to reinforce the behavior for change. That's essentially what it means. Okay. And it's most basic term is called pay for P, right? Very effective, The reason why we do urine toxicology screens in the beginning and at the end of the week is because it takes the urine tox screen via immunoassay will detect methamphetamine use or substance use within about 3, at most 4 days, but typically 3 days. So if you do the math, you do beginning of week, end of week, you will catch the vast majority of a person's use for that entire week. So you're pretty confident knowing whether or not they've used or not used during the time that they've been in treatment. So again, the behaviors you're targeting is drug use primarily with the tox screens, but you're also targeting counseling attendance because the patient has to come in order to do the tox screens. And it also gives you the opportunity to implement what I just spoke of, which is motivational interviewing and any of the other permutations of treatments that I'm going to outline in the following slides. Again, the reinforcers are primarily vouchers and they have some monetary reward. We do not give out money. Okay, that's something that we don't do. But we give vouchers that have some kind of monetary reward, and Katie will give you ideas of what that is in the following slides. So one of the ways that we reinforce or we give this positive affirmation or this voucher is through a fishbowl technique method. And this was developed over in Johns Hopkins by Dr. Stitzer. It's very effective. What it is you put a bunch of God, I'm blanking on a bunch of vouchers into a fishbowl, right? And you're going to put a few vouchers that are of very high monetary reward. And then you're going to have more vouchers that are going to have less of a monetary reward, and you're going to have even more vouchers that are going to have, oh, good job, you're doing great. So it's basically a lottery is what you're having the patient engage in. But the stimulus of knowing that there's a very high monetary voucher there, just like the lotto, right? There's millions and millions of dollars, is going to elicit people to want to draw and get a negative urine so that they have the opportunity to win each and every single time. And that's, a positive reinforcer in the side of the patient for engaging in treatment. They'll get a draw for each negative urine. The number of draws can escalate depending on how long they've been in treatment and how many urines they've had negative. And there can be a bonus draw given if there's consecutive weeks of abstinence from methamphetamines. So this just goes back to talking about how you're going to gauge these vouchers in the fishbowl and how much of each you're going to give. And this is an example here where the largest chance of winning is going to be a small prize like $1. A moderate chance of winning is going to be a larger prize like $20, and then a small chance of winning a jumbo prize of $100. This is just one example. This isn't necessarily the way that every program would do it. But this also goes back to the concern of, okay, well, monetarily, this is going to be a big ding in the budget if we have high monetary prizes each and every single time someone has a negative urine. And this is a way to kind of minimize that, to be within reason, but also still be able to elicit the response that you need for negative urines and success in the program. And if you look at studies that are published using this strategic method of contingency management for methamphetamine use disorder, you can see a clear separation between those that had standard behavioral treatment, which is the first line on top, versus those that were engaged in behavioral treatment. I'm sorry, standard treatment on the bottom, behavioral treatment on top. You can see a clear separation here. So it's very, very effective. So community reinforcement approach, this is one of the things that we have a lot of data showing that it's very effective in adolescents in particular. And what you're doing is you're trying to find other ways of finding a positive engagement or a positive experience away or moving away from substances. And you do that through various techniques. So some of these techniques are exactly what I just said, functional analysis of substance use, having a person really look into the negative consequences of their substance use and how you can change that, building relationships, and that can be via counseling because counseling can help a lot in making sure that relationships are, they have a framework for how to repair relationships, and what kind of things are they doing that are consequential in developing negative relationships, and how you can make those more positive. Vocational skills and jobs training so that they can engage in productive activities outside of substance use, and really and become a functioning member of society. Therapy, and recreational activities are very, very important. In fact, there's a lot of studies out there indicating that exercise alone has a great effect in an individual's ability to abstain from using methamphetamines. And studies have shown that people that engage in exercise on a regular basis are more able to sustain abstinence from methamphetamine use than those that do not engage in regular exercise. So it's a very big part of what a lot of people are recommending, especially in community reinforcement approach therapy. Cognitive behavioral therapy, very important to do as well, because unfortunately the reality for a lot of our patients, and the limitations of what we're able to do for our patients, is that we can't always change their environment, unfortunately, but we can change the way people think about their environment or what they're facing, and spin it in a way that's less negative and more positive towards them having less depression, less anxiety, less drive to want to go and self-medicate themselves with methamphetamines. Takes a while. It's not an easy thing to do. It doesn't happen overnight, but it is something that can be unlearned, and one can change and shift their thought process. This goes back to when you look at a cup, is a cup half full or half empty, type of example. So, patients change the way they think. You got to find a way to tailor to their needs or their individual environment and what it is that is causing them to have negative thought processes, rumination over negative issues that are going on with their life, but it has to be specific to that patient's lived experience. And typically the therapeutic sessions last anywhere from 50 minutes, and typically 5 to 10 months in order to see, positive effective change with cognitive behavioral therapy. So, as I said earlier, the psychosocial treatments that I outlined are really what you want to focus on, because that's where you're going to get the most effective change with patients. Medications are an important tool under belt that can be used to supplement the psychosocial treatments for methamphetamine use disorder. Now, some of those are outlined here, specifically for methamphetamine. Now, I want to tell you guys, none of these are FDA approved for methamphetamine use disorder. And this really goes back to what I said earlier of the number needed to treat, meaning how many people do you need to treat to have the desired outcome that you're hoping to get from the intervention. The number needed to treat is very high. So you need to treat a lot of patients in order to 100% to 100% with confidence have the outcome that you're seeking, which is less methamphetamine use or abstinence of methamphetamine use. That's the opposite for many of you are familiar with methadone and buprenorphine. That's the opposite for those, right? So to give you an example, the number needed to treat for buprenorphine for opioid use disorder is 2. You really only need to treat 2 patients to to assure yourself that you're going to have 100% efficacy as far as the outcome, which is abstinence from opioid use. That's a really small number, right? In fact, many of the interventions that you get in primary care don't even come close to that number. An example of that is if someone had a myocardial infarction, a heart attack, goes to the emergency department and gets aspirin, which, most people would probably sue if they didn't get an aspirin. But if they were to get an aspirin, the number needed to treat is very high. It's anywhere from 35 to 50, depending on the study that you're looking at. So just to show you how effective buprenorphine is. But these medications are not, at the level of buprenorphine. Nevertheless, they're important because there are studies that signal that you can get a decrease in methamphetamine use if you use these medications or combination of medications. There's a study that came out in the New England Journal of Medicine that used a naltrexone long-acting injectable, also known as Vivitrol, with high-dose buprenorphine, also known as Wellbutrin, which is an antidepressant. And they did get a positive response in lowering methamphetamine use, although the effect size was small. Mirtazapine, also known as Remeron, is also an antidepressant. There's two small studies that showed a positive correlation with decreasing methamphetamine use. We often use it in our program. Buprenorphine alone, Wellbutrin, which I mentioned in the first bullet point. We've also seen studies with low-level users that were able to decrease their methamphetamine use. We use that in our program as well. Topiramate, we've been able to use that. But again, low-level users, what that really means is individuals aren't heavy users. They're not using on a daily basis. Most of the studies are going to categorize that as maybe 1 or 2 times a week of use. And, unfortunately for a lot of the patients that we treat, that's not really the case. Nevertheless, we still use the medications because they can still have some benefit. And then naltrexone alone has been used, the oral tablets, not the long-acting injectable like Vivitrol. Now, I always get this question, and I put these up there because I always get this question is like, well, how about stimulants? Can we use stimulants to treat them? Well, there have been studies where Ritalin or methylphenidate and dextroamphetamine have been used to treat those individuals with methamphetamine use disorder. There's been mixed studies as far as, having a positive effect or not having any effect at all. What I usually tell my partners out in the community is, unless you're in a very controlled environment and you have someone with expertise in addiction, you probably don't want your primary care doctor or someone that doesn't have the added support or to do this. And because it requires a lot of monitoring, it's a controlled substance. Things can get out of hand if you're not really cautious and you know what you're doing. So I wouldn't really say that these are available for prime time out in the community yet. You will find studies on it, and you will find some, academic institutions doing work on this, but not something that I would recommend just the average Joe clinician doing out there in the community. I would much rather see them do what I outlined above as far as medications. When it comes to cocaine use disorder, things are a little different and a little similar at the same time. So Zoloft or sertraline have been used and has shown some evidence. Topiramate for low-level users again. Modafinil, which is a little controversial because we're starting to get into the controlled substances now. And then, as I said, there are studies indicating that stimulants have been used. But again, that's something I would recommend and not really for prime time just yet. This is just a reminder, like one of the slides I mentioned earlier, our problem here in San Diego and across the nation is really opioids and methamphetamines and mixing the two. And this is just a reminder that we've gone from heroin, which was causing a lot of deaths, to fentanyl, which is much more potent. And what you can see here depicted is the potency of heroin or equal potent doses between heroin and fentanyl. In order to get the same effect from the amount of heroin you see here, you can see you need much less fentanyl. And if you're looking at carfentanil, which is always a concern, and we have seen it in some parts of the nation, you need even less of that in order to get the same effect. So, these people that are putting these drugs together, they're not rocket scientists, right? They're not in a laboratory. They're just putting stuff together, and you can see here how easy it is to make a mistake and put too much and cause the deaths that we're seeing. So because of that, we really need to get naloxone to everybody out there, whether they use methamphetamines, whether they use heroin, opioids, fentanyl. I would go as far as saying if they use any substance, cannabis, ecstasy, psychedelics, whatever it may be, I would always encourage everyone to give naloxone or offer it to the individual, because chances are they're probably going to be using with someone else that may get their hands on some opioid, so they're there to help revive them. Every time someone gets revived by naloxone, the chances of engaging in treatment are significantly higher. And like I said, there's a lot of things that are laced out there with fentanyl that people otherwise would not have known, such as Xanax that they think they're getting illicitly from the street. We've gone over cocaine and methamphetamines, and the list just seems to be growing as the years go by. These are the two formulations that were typically available at the pharmacy. One is an injectable, one is a nasal spray. I encourage everyone to just give the nasal spray. It's the easiest one to use. It's just as effective. And again, nobody needs to die from an opioid overdose. So what are the key principles really when it comes to methamphetamine use and treating a person with the interventions that I outlined before? The key or the first thing is really avoid confrontation, right? That's really key. You don't want to turn this into a confrontational session between one's ideals versus another person's ideals, because the point is to really build a therapeutic alliance with the patient, feel that the patient, the patient feel that you have their best interest at heart, and that it's a safe place where they can engage in care and say whatever they need to say, and not receive the negative consequences that they would anywhere else, right? And it really needs to be a safe place. If you start from there, then everything else is just going to get better down the road, right? Because everyone wants to feel that they're able to go somewhere where they belong and where they're safe. You need to meet patients where they're at. And what I mean by that is if they're not ready to engage in contingency management or treatment or whatever it may be, fine. Doesn't matter. The motto is always a patient under our care is always better than a patient not under our care. And if that's just means check-ins with the patient and doing motivational interviewing, and spending 6 months with them doing motivational interviewing to get them to make effective change, and so be it. That's what we need to do to get them there. And once you're able to make effective change with motivational interviewing, you can move into contingency management, community reinforcement approach, cognitive behavioral therapy. You can use counseling plus meds. You can use a whole smorgasbord of things that you have available to you, but it's not going to happen until you really build that therapeutic alliance. Then frequent follow-ups are key in order to build that alliance. And don't forget exercise. Always recommend a patient engage in exercise. Like I said, the data is very robust in that. And follow up, again, I can't state that enough. Make sure you continually follow up with the patient, even if you feel like you're not making any difference. Meaning, a lot of clinicians out there think that if they're not prescribing something, they're not really doing anything. And that's really not true. As I mentioned, there's a lot you can do with just conversation alone and motivational interviewing. And you just want to make sure that you monitor a patient to make sure that they're achieving their own goals, right? If the goal is small, the goal is small. Meaning, they come in and say, Doc, I'm just going to work on not using methamphetamines for a day out of the week. Fine. Okay, let's start there, or the weekend. Any little thing that they can do to change is just one thing that may lend that little snowball to turn into a bigger snowball down the road. And look at your EMR and see if there's a way that you can use your EMR to your benefit for making sure that you look at population-based tracking and seeing how patients are doing in general when you get them into an SUD program that's established. And with that, I'll give it over to Katie.
All right. Thank you, Dr. Sepulveda. Again, my name is Katie Wood, and I am the Senior Director of Special Populations at Family Health Centers of San Diego. As it relates to this presentation, I oversee the operations of a variety of different programs, including our substance use disorder services, our syringe exchange or syringe service program, harm reduction services, and a variety of other different programs and service lines that we have that offer low barrier access to medications and treatments for substance use disorder. So today I will be talking about the Recovery Incentives Program, which is California's contingency management benefit through the Medi-Cal transformation. They opted to call it recovery incentives versus contingency management, but they are synonymous in this presentation. Next slide. So what is the Recovery Incentives Program through Medicaid or Medi-Cal. So as we all know, California, we're grappling with persistent and shifting substance use disorder crises. Here in San Diego, we have a high prevalence of stimulant use disorder. Deaths related to cocaine, methamphetamine, and other stimulants have been on the rise and have trended up in the past decade. So contingency management, as Dr. Sepulveda outlined, is the most effective evidence-based approach to treating stimulant use disorder. And as we heard, the treatment has demonstrated robust outcomes, including reduction of use and longer retention in treatment. So California opted in to the pilot program through Medicaid, which was launched by DHCS in partnership with UCLA in 2023. Each county had the opportunity to opt in, and San Diego did opt in and has 3 pilot sites that are currently offering the contingency management program. So as Dr. Sepulveda mentioned, the primary target behavior is stimulant non-use, and that is demonstrated through urine drug screens, which I'll talk more about later. And in this particular program, participants can earn up to $599 while they're participating in the program. Of note, California is the first state in the nation to cover contingency management as a Medicaid benefit, and they're currently evaluating the effectiveness and of the treatment at a large scale. So in short, the CM program within the pilot uses a structured 24-week outpatient program followed by ongoing support. It is offered as a standalone service, but it is included in the outpatient treatment programs here in San Diego. So whether somebody wants to co-enroll and engage in treatment groups, they can do that, but they can also opt out of it. They are required to do a full intake to enter into the program, although if they do the contingency management or recovery incentive track alone, they are only required to do the twice weekly urine drug screens. And monitoring is in place for all of the pilot programs just to confirm that they're following the evidence-based practices and the standards to fidelity, which is crucial for any evidence-based practice. Next slide. So just for this talk, I'll include that this program for Family Health Centers is offered at our Behavioral Health Center on Fifth Avenue, which also includes our treatment, our intensive outpatient and outpatient program. We also offer case management. We offer these services. Again, if somebody does not want to enroll in the outpatient program, we still evaluate and offer therapy, case management, other services. We do same-day screening and appointment, and we have extended hours to support individuals who need evening services. Next slide. So for the Recovery Incentives Program, there are specific qualifications that somebody must meet. First of all, they do have to have active Medi-Cal. We do recognize that is a barrier for some of the population, but because it is a state Medicaid pilot, that is one of the requirements. So at screening, if somebody does not have Medi-Cal and they have a stimulant use disorder, we are not able to enroll them in the Recovery Incentives Program, but we're able to enroll them in the other service lines and address their stimulant use disorders through some of the other evidence-based practices that Dr. Sepulveda mentioned. Right now, this is offered for individuals 18 years of age or older. They do have to be enrolled in a drug Medi-Cal organized delivery system treatment program, which is basically a county-funded program run through our local behavioral health services. They cannot enroll in the contingency management without doing an intake into the actual treatment program, but they can opt out of those additional services. The individual must have a primary, secondary, or tertiary stimulant use disorder. So that can be a methamphetamine use, amphetamine, or cocaine use disorder. It does need to be moderate to severe. If somebody is in remission due to being in a controlled environment, for example, they recently were exited or were formerly incarcerated, or they've completed a residential treatment program, there are some specific stipulations of who we can enroll even if they're in remission. And participants cannot be enrolled into programs basically in the county, meaning they cannot participate simultaneously in 2 different contingency management programs. They can only be enrolled in one. And the only exclusion to that is if somebody is enrolled in treatment services for medications for addiction treatment, they can be co-enrolled regardless of where they're receiving their MAT services. So for us, the program is Mondays and Thursdays. So as was discussed earlier, there's the timing is key. You don't want to have patients come in to do a urine drug screen on a Monday and a Tuesday. You need a couple of days between them coming in for the program. So for us at Family Health Centers, those are our designated contingency management days. The coordinator essentially does the instant urine drug screen. We have CLIA wave testing, which allows the programs to offer the instant testing on site. So somebody submits their sample, and within a few minutes, those have resulted. And regardless of the immediate results, there is a brief check-in. The counselor will add those results into the portal. They'll have a brief discussion with the patient. If they have tested negative, then they do an incentive calculation. They also get some kudos and some positive reinforcement right then and there from the counselor or the contingency management coordinator. They have a brief discussion. If they have tested negative for stimulants but positive for say opioids, for example, then they have a discussion about the positive for opioids, and they get a referral to an MAT program. Otherwise, if they are negative for everything, or regardless of, they have to be negative for stimulants, but they get that incentive. The way that the state has run this model is through an online portal. The patient does not get handed anything immediately, but they have access to the same bank. And essentially, we'll get into what they earn at each negative urine drug screen, but those get added into an online portal where they have access to cash out or to bank their earnings. If there are abnormal findings in the urine drug screen or the individual has tested positive, they still meet with the counselor, they receive counseling, they receive continued support. There are discussions around perhaps what led to the individual using a substance, if there was a lapse or a return to use. There are discussions, but again, the individual is not required to enroll in treatment. So these are just one-on-one discussions that happen at every single urine drug screen. Each session is around 15 minutes, so it is intended to be low barrier. If somebody needs additional support services, if they want to meet with a counselor for longer, if they want to meet with a therapist, if they want to enroll in treatment, all of those services are offered at each of those visits. So this is the state's kind of allocation of funds. So this chart is depicting the full 24 weeks of the program. It is broken into two phases. There's week 1 through 12, and then weeks 13 through 24. During the first part of the first 12 weeks, urine drug screens are collected twice weekly. The incentives start at $10 for each negative sample, and for each negative sample, $1.50 is added to that value. So their first test is $10, their next one would be $11.50. If they continue to test negative, they get $1.50 gets added to that base of $10. Once they get into the stabilization period, which is weeks 13 through 24, they drop down to doing urine drug screens once a week, and there's different value amounts depending on the week that the person is enrolled in. If somebody does test positive at any point in this, they do not lose all of their previous earned incentives. They drop down to a certain value for a week or until they test negative again, and then they go right back into wherever their escalation period, escalation of funds was. So we really don't want to be negative about somebody having a lapse or a return to use. We want to support and encourage them. And so this is why the escalation of funds was allocated in this way. This just shows the variety of different incentives that people can have access to. And I'll get into some more in our success stories about some of the ways that people are opting to spend their earned incentives. So there's nothing on this slide, partly due to the fact that California is still in the pilot phase. There is not a lot of public-facing data at this time. Locally, the San Diego County Behavioral Health Services is the one collecting the data at the program level. So as a pilot site, I can share with you that the pilot launched in 2023. I believe the first program started offering services in early 2024. So far, the data shows that there have been 247 members who have enrolled. Of those 247, 55 people have completed the full 24-week program. In a monetary kind of value, that means that there has been a total of over $60,000 that people have earned throughout the entire program of testing negative for stimulants. It's interesting because only $53,000 have been paid out, and we have seen that if people do have a lapse or a return to use, sometimes they don't return. They had been banking their incentives, and we do our best to try to get those funds back to the person, but sometimes people opt to disenroll and they do not cash out their bank. So that's why there is a discrepancy between the total number of funds that have been earned versus what has been paid out. From those 247 members, there's been a total of nearly 4,000 drug tests that have been collected over the pilot phase. And I found it really interesting that out of those nearly 4,000 tests, there were only 4 positive for opioids, which I think is really interesting, especially as we look here in San Diego and the comorbid use of stimulant use disorder and opioid use disorder. And so I found that very interesting. Not sure what that indicates. Could be a higher prevalence maybe of people enrolled in MAT programs once they're enrolled in CM or vice versa. I know for family health centers, we advertise this very strongly with our MAT program. So if somebody does have a stimulant use disorder, we do our best to refer them and engage them in the contingency management program. So not really sure. It'll be really interesting once the pilot phase ends to see all of the data analysis and to see, hopefully this will continue as a benefit for California and across the nation. So there are some challenges that we're seeing. Keeping clients engaged in any kind of treatment program for 24 weeks can be challenging. Anecdotally, we do hear that there is treatment fatigue. People have either been in multiple programs in their life, or they are just tired of coming in and doing twice weekly urine drug screens. There's a variety of factors that we're just anecdotally trying to evaluate to understand why patients don't stay. We see a pretty significant drop off once people go from that phase 1 to phase 2, coming twice a week versus once a week for the urine drug screen. Once they have that 12 weeks completed, a lot of people find that successful, and that is successful, and they opt to not continue. So it is challenging, which is why it's a low number, right? 55 out of the 247 who have completed. Keeping clients motivated to continue, that's really the challenge. And there's also less interaction and less engagement. So we're just evaluating those contributing factors to why people are not staying on past that 12 weeks. And then we also see a pretty significant drop off for people who are really close to completing 24 weeks. They are ready to be done and they opt to end their time with us, even though at the very tail end, the incentives actually increase for those who make it to those final weeks of the program. So we're currently working through that and just collaborating with others here in the county because I think most of us want this to be a successful pilot so it gets adopted as a Medicaid benefit. But not sure of the timeline for that, but those are just some things that we are seeing here at Family Health Centers. So I have a couple of success stories, and as you hear these, if you talk to other programs, the success stories are really amazing. They're just the life changes that we're seeing we're really proud of each of these members. So I'll give you 2. So one particular member enrolled earlier this year. They were self-referred. You can see their drugs of choice, PCP, methamphetamine, THC, and heroin, and they were injecting. They had a period of sobriety prior to enrolling, but they had recent triggers due to their status of being unhoused. They were unemployed, reported little support, whether that was familial, little peer support, not a lot of community engagement. And they did enroll in our formal outpatient treatment program, and they were housed through our recovery residents. So came in unhoused, but we were able to get them into housing. And because of their drug of choice of methamphetamine, we offered contingency management. They did accept. They successfully completed the full 24-week program. During their time in treatment, we had also referred them to smoking cessation classes, which they attended. They enrolled in enhanced care management for additional support regarding their homeless status and their employment. They, on their own, attended 2 to 3 self-help meetings per week to really build that community support, their recovery support. Towards the end of their time with us, we were really proud to learn that they became a house manager at one of the local recovery residents. They actually enrolled in the peer support certificate program through the state and are underway to become a peer support specialist. And they used their incentive monies, so they earned the full amount to purchase items for their children. So toys, school supplies, clothes, and shoes. Next slide. And the next success story is somebody who enrolled last year. They also had a methamphetamine and opioid use disorder. They were also co-enrolled in our intensive outpatient program. And coming in, this person was very clear that their goals were to abstain from substances and to lose weight. So in the beginning, she was getting her incentives. She was buying pizza. That was her favorite reward. And a couple of weeks in, she decided and really became kind of congruent with her goal of losing weight, made the decision to focus on her health. From there, she spent all of her incentives on purchasing workout equipment, workout clothes, everything to support this goal of hers of losing weight. She started to work out daily. And through this new routine, she discovered her self-esteem, her confidence, and she also completed the full 24-week program and maintained abstinence from both methamphetamine and opioids. So it's really powerful once you start to, get into these success stories just to hear, and the clients themselves are the best advertising, right? They share their stories with others. Other people hear that they have been incentivized through this recovery incentives program to support their recovery journey. And it's just been really amazing to see and hear. A lot of our clients do opt to bank their funds. And so we've heard of people wanting to buy big purchases. So whether it's, bicycles for their children. We had one client who had never had a brand new pair, I think it was of Nike Air Jordans, and saved all of his funds to cash out and purchase that. So it's very, very rewarding to see all of the successes that are coming out of this particular program. So lastly, I just want to give you the information. Like I said, there are 3 pilot programs in the county outside of family health centers. If you're wondering where you can get that information, it is on the county website. So you can go there and see what regions or which programs are offering this service. Again, for family health centers, it's at our 5th Avenue location. We do have a flyer. We're happy to provide these to you or to the community if you're interested. We do have a referral line. Somebody can call that referral line or call the program directly, and we will get them the information and hopefully get them enrolled in contingency management. The rest of the slides are references, so we don't need to go through all of those.